good afternoon, and good evening, everyone. Welcome to this week's Global Cafe. As mentioned, my name is Roxana, and I'm very excited to be moderating today's just incredible discussion with one of the Healthy Aging 50, Dr. Yun-Hee Jeon, with the topic of why do we need person-centered care beyond a philosophy in the care of older persons. So thank you for joining our conversation today, Dr. Jeon, especially because it is quite late in Sydney, Australia. So we do value your time today. Now, to get started and to brief everyone in on her background, Professor Yun-Hee Jeon is a Susan and Isaac Wakil Professor of Healthy Aging at the University of Sydney and the Director of Step Up for Dementia Research and Step Up Aging Research. Yun-Hee has expertise in dementia and aged care models of care, focusing on person-centered care, reablement, and rehabilitation, as well as clinical leadership in long-term care settings. Yun-Hee leads a number of initiatives for public and patient involvement in research and citizen science. Her commitment and contribution to healthy aging research and long-term care was recognized by the UN Decade of Healthy Aging as one of the Healthy Aging 50. So, Yun-Hee, you have an incredible and extensive background in the field of healthy aging and age-friendly environments. What prompted you to go into this field, and how did you transition your career to eventually lead to the work of Step Up for Aging Research?
Thank you, Roxana. Good morning, good afternoon, good evening. It's my absolute privilege and pleasure to be speaking with Roxana today at IFA Cafe. Before I begin, I'd like to acknowledge the traditional custodians of the land, Gadigal people of the Eora Nation, from which I'm speaking today, and I pay my respect to their elders, past, present, and emerging. And I'm very pleased to be here today, and thank you for the invitation. Now, how did I start the journey to healthy aging research? I am from South Korea, and I came to Australia about 35 years ago. And my background is a registered nurse. And I work with a lot of nursing students and nurses and other care staff who are providing the care of older people. Now, I didn't start with the healthy aging in my mind when I first started doing research in this area. It was about 25 years ago. I was very interested in social justice and also supporting people who don't necessarily have voice in our society. And my journey started with working with the families of people with severe mental illness. And through that process, I learned enormously about the importance of those people affected by health issues and their lived experience, how we actually learn as clinicians and researchers and educators to inform our practice and training and policy decision-making. So my work in dementia and aged care started about quite early 2000. That's after my PhD. And this was when I was exposed to, I use the term exposed because it was my work environment that really prompted me that I really need to look into this person-centered care. And person-centered care, many of you may have heard about Tom Kidwood. So my understanding and principles of person-centered care are very much underpinned by Tom Kidwood's work about how best we provide care for people living with dementia. And through the journey of understanding how we support nurses and care workers and managers to provide a person-centered care, I was beginning to really think about broader issues. So often person-centered care is understood in the context of how individuals provide care. And often the responsibility is left to those who are providing care, but not necessarily those who are providing, the resources and work environment and also government policy levels. So that really opened my eyes around how best we could actually address other issues that directly influence person-centered care. And also started working with the people in the community, as well as residential aged care homes. And I guess, through the process, I, worked with a lot of people who have dementia, who live in residential aged care with or without dementia, their families and care staff. And multiple times that I learned about how little we knew about supporting individuals to maintain their independence in the way that they define. And so, so in the last 10 years, I put a lot more effort into the notion of how do we actually support those older people in care to have that experience of a sense of independence. And I started working to develop models of care and evaluating those models of care under the name of reablement. So I think, working with the people, with the lived experience, that has taught me enormous, far more than, my reading of literature or training. And that really, helped me grounded in the way that I work with people. And I guess, during the process, I also started thinking about how best we could actually give them voice. So when I say give them voice, not just as those who are receiving care, but also those who are, participating in research. And that's how I started, developing Step Up for Dementia Research and Step Up for Aging Research. So, I'm an academic, I'm a researcher, and I guess, from my last 25, 30 years of research experience, one of the things that we struggle most is how best we include people in our research studies. And at the same time, we often hear from the public saying that, well, I want to participate in research, but I just don't know where to go to. And so when I, found out about this program that has been running quite successfully in the UK, Joint Dementia Research, I thought this is something we should start in Australia as well. So, so that's, Step Up for Dementia Research and Step Up for Aging Research. That's where we are at now. So both of them are, simply put, it's an online dating for the public interested in dementia and aging related research, with researchers doing research in those fields. So we invite people to sign up, come to our website or call us and ask them to actually say that they are interested in participating in research. And then researchers like myself who have studies that have ethics approval come and register, and then we can match those who are eligible for research, and the researchers, they can actually start talking to each other. So this is the kind of program that I've been working on. And more recently, that we have, I've been involved in developing how best we could actually give more voice to the public and those people with lived experience to participate in research, not just as a research subject, but as, those who are collaborating, co-contributing to research processes. So, so it's a lot to cover, but I think, Roxana asked me to talk about healthy aging and then step up for aging research. The journey is quite broad and long, and I'm very happy to explain more details later on if anyone is interested. But what I want to say is that my journey started with how best we provide a person-centered care, and even 25 years later, that person-centered care principles underpin everything I do in my research and in the way that I work with other people. And I guess, this is something that I would like to really, emphasize that that nowadays some people are even becoming, or having some adverse reaction to person-centered care because people talk about, well, we all talk about it, but no one knows how to do it. And so I'm very happy to talk about more details, but I think we need to make sure that we don't throw a baby out of bathwater just because the terminology has been used, often, but that it's not happening doesn't mean person-centered care itself is wrong. It's how we actually deliver. We haven't been able to, make it more system-wide approach.
Thank
Does
you.
it help you?
No, absolutely. Thank you for that. That was very comprehensive. And I guess building off of that, can you detail and let us know what exactly person-centered care kind of looks like, what it means? And would you say that it is routinely part of older adult care as well?
Yeah. So, person-centered care is often, when you go to long-term care setting or aged care homes, or when you talk to someone from aged care organizations, often person-centered care is part of their organizational principle. So it's our vision or our mission, and our staff provide person-centered care. But when in fact, when you speak to those people working in the organization, you may not necessarily see that. So the way that I explain person-centered care is that it can be individual's care approach to the person, whether they have dementia or not. And my, talk today is very much around those older people in care, whether they are in their own home or in the care home setting. So, when we say my approach to the person and providing person-centered care, I need to understand the person's needs. So the needs could be their physical needs, could be their psychological needs, social needs, or environmental needs. So it's about understanding individuals' needs, but also in the way that we support their needs has to be respectful. With respect to the person. So look, understanding the person's uniqueness as an individual. So it sounds really like, something just say in the paper, but when we interact with the person, we need to understand the person as an individual. So it's not a resident number, 1 or 2 or 3. It is the person who has, who used to be a teacher or who used to be a nurse, who has, children, grandchildren, and who has a particular preferences and their, wishes. So to me, the beginning of person-centered care is about knowing the person. And knowing the person isn't just about their medical needs knowing, it is about the person as an individual. So that's the very first step. And then, I guess, understanding the person's current wishes and preferences. And these are the things that are often dismissed when we provide care to a large group of people. And that's why, often we hear that person-centered care doesn't exist in aged care homes because, if you have 150 residents in a care home environment, and then you have staff members doing things day in and day out, And, if they don't have sufficient time to know the person, it becomes very difficult to understand how best they could provide a person-centered care. So it's about building a good relationship with the person after knowing the person, but also, we talk about this give and take. So reciprocity is very important. And I've learned so much by interviewing over 100 people living in aged care home. So these are the people, some people have dementia, others don't. And I asked them what matters most. The most frequent answer was a family. Apart from the family, what they wanted most was having sense of independence. That sense of independence is regardless how individuals or they frail they are, whether they have dementia or not. There was, the most commonly mentioned what mattered most to them. And I met with this, a person who was 2 months, like a 99-year-old, and she was about to become 100-year-old in 2 months. And she was living alone in 4-bedroom house in a rural, area. And she was more independent than anyone else. She was frail, she needed lots of help, but she was able to do things in her own home in the way that she wanted. And she was receiving community support, but she was supported to do her own things. So I think this is one example of providing person-centered care. It's understanding that independence is most important for that person. It may not be for everyone, but understanding then how best we provide the support. So often, when someone has dementia, then, we see that clinicians, when they talk to the person with dementia and the family, they may not talk to the person with dementia directly with an assumption the person may not understand. So the first step is you have to talk to the person rather than talking to the family first. So, so these are the things, it may sound very small, but that makes huge difference to the person's confidence. So it's really important that we are actually treating those people, especially those who don't have necessarily the voice or confidence to talk about what they want. And so the person-centered care does address that. If you're providing person-centered care, this is something that you have to really address in terms of treating the person as a unique individual, not as a person with dementia. And therefore, we are making lots of assumptions. It's also about understanding the person's needs, not just physical needs, but also social needs and medical needs. And so these are the things that we have to think about how best we, provide a person-centered care. And I find it quite challenging when a system or a particular model of service is provided and everyone works on task. So, one care worker may work, provide, shower for, many number of residents. Another person comes and does the medication only. Another person comes along and do other things. So it does become, care becomes a task. So rather than we are actually understanding, providing that holistic approaches to care. They may understand the person holistically, but they may not have that opportunity to provide that holistic approach.
Thank you very much, Dr. Jeon. For our next question, may I actually ask Mr. Dominic Boyd to unmute and pose your question that you put in the chat?
Oh, sure. Thank you very much. And appreciate the opportunity to talk. I worked in 2 different nursing homes early in my career. And they were one was municipal and the other was a non-for-profit. And we say that things start at the top. And we think about board structure, we think about management practices, we think about licensing, I'm in Nova Scotia, Canada, and there's provincial licensing requirements for long-term care. So I'm thinking, what have you found in your work regarding what's most important? What are the most important factors in creating person-centered care when we think about those higher, sort of larger aspects beyond the family involvement and the personal involvement, which of course are crucial. But
Yes.
how can we actually structure our institutions and our laws and licensing and so on, board structure, that sort of thing, so that person-centered care is embedded? Thank you.
Thank you very much for the question. That's a really timely question because we conducted perhaps the world's first randomized control trial, which is considered as a gold standard research methodology to show evidence on interventions. We tested person-centered care so the study was conducted in 15 different aged care homes, and the 5 aged care homes received person-centered care intervention. 5 care homes received dementia care mapping, and the other 5 usual care. So they didn't receive any special care or intervention. And we were able to demonstrate person-centered care did improve individuals' well-being by reducing agitation and aggression of those residents with dementia. After that landmark trial, of course, we are very, pleased to see positive outcome, but I felt like, that wasn't actually enough to me, that our results should have been a lot more positive. And the thing that we observed is that the way that the managers engaged in the whole process. And so some care homes, managers, as you understand, middle managers, I'm not necessarily talking about top CEO level executive managers. So each care home is led by or managed by care manager or directors of nursing. And their role was so important. It doesn't matter what we do, how well we work with the staff members to train them, to help them understand how best they can provide person-centered care. If the manager was not engaging or supportive of the work that the staff members learned to deliver, it didn't actually work well. So the next, major trial we did was that how we actually support managers to provide the support so that their staff members can provide a person-centered care. And it was interesting because a lot of aged care service providers or organizations had their own leadership program, to support their managers. And often those management, the support programs were 3 days, training or 5 days training, and they don't necessarily bring changes in the practice. And so we really introduced the, practice-embedded clinical leadership program and tested whether we could actually improve managers' leadership style and their capabilities. And we were able to demonstrate that. So what we learned was that leadership, you don't have to be born with the leadership skill sets or elements. We could actually support managers to actually work well with their staff members and provide their support. And one of the things we also developed was a clinical leadership framework. And the top key element of the framework was that the leaders are able to support their staff members so that the staff members can provide a person-centered care. Without the support from managers, it's very hard for staff members to practice what they have learned. So another thing that we learned was we did a similar study in a very small organization. What we noticed was that it isn't just about training leaders or supporting leaders to make it work. It's how that organization actually supports their leaders. So it felt like we were coming around the full circle in a way, that just providing training of a person-centered care to staff members to do better care is not the best way. We really have to change that organizational culture. To do that, the organization has to appreciate that, training staff on person-centered care alone isn't necessarily going to bring about the change. So, I think it's about that organization culture. But what I found was that often people, whenever we talk about leadership or organizational culture, people dismiss them because, oh, we know that, where we all do that. They are one of those things very hard to target. So, so I think it's important that then, what about policy level? There should be something about leadership. How do we measure that leadership? So those things are the things that we should really pay attention to, in addition to training staff members, because they're not necessarily sustainable. I don't know about other countries, but in Australia, staff turnover in aged care is a very significant issue. And so if you train your staff members to deliver person-centered care without having the organizational culture supporting staff members, when the trained staff leave, then you've lost the resource. So I think this is something that we really want to emphasize, but something that I find, not easy to really bring about the change. It's not that we don't know, it's something that we have to keep talking about it, and we keep pushing the government to really focus on those important organizational level leadership and support.
Thank you very much, Yun-Hee, and thank you, Dominic, for the question. In the chat, Mr. Darren Evans also posted a comment regarding some of the barriers and challenges with person-centered care. Darren, can I please ask you to unmute to speak regarding your comment?
Yes, certainly, Roxana. Hi, good day and good to see everybody here. My experience really comes from 25 years plus of technological development in social care environments. So we've provided solutions to care companies, care homes, NHS, and a whole raft of health and social care organizations. And what I've seen from experience is that most systems that proclaim to be person-centered are really operational management systems, whether that's strategic end-to-end workflow or clinical systems or governance or reporting or KPIs and et cetera, et cetera, et cetera. It doesn't actually start with the person themselves. And that is, I think, one of the main issues. And so for me, real person-centered care starts with the individual. What are their hopes? What are their aspirations? What are their likes? What are their dislikes? What is their history? What is the background to that individual? And I think a lot of that gets missed. And certainly with specific regard to anybody with a dementia diagnosis, music tends to be a catalyst for cognitive recall, and that's proven. So I think that needs to be involved in some level of person-centered care as well. So yeah, hopes, aspirations, and all that comes with.
Thank you, Darren. I wholeheartedly agree with what you've just said. And music is definitely one of those powerful, sources to really lighten up some of those people who love listening to music. Like all other, interventions or resources that we use, I guess, it's very much individually tailored approach, isn't it? So there are many different types of interventions, including music, we could offer. But as you said, it's about understanding individuals' history and the past, and as well as what they want right now, right at this point, and understanding and being able to offer those things. What's challenging in an institutional care environment is that, and as I mentioned earlier, that staffing does matter. When you have 150 residents in a care home, and if you have a insufficient number of staff members, or if you don't have sufficiently skilled staff members, it is very hard to provide the person-centered care, because how do we actually ensure the staff member has the time to actually get to know the resident and being able to provide that, individualized care and support. So to me, the person-centered care shouldn't be just about, individual staff members' responsibility. It is their responsibility, but there has to be organizational structural support that allows for staff to be able to practice what they understand. But also, Darren, your point about starting with the person, absolutely. And I guess, this is where the individual approach comes in, isn't it? Like, if staff members doesn't actually appreciate individual residents' preferences, it is very difficult to provide a person-centered care. At the same time, the very same staff member may have done what she or he is required to do during their shift, doing the task. So this is a very difficult, thing to measure from the, documentation point of view. The person, the care worker or the nurse may have ticked everything they are required, but the person may not have done person-centered care in the way that we are talking about here. So that's the challenge when our accreditation or care quality standards are based on certain measures that may not reflect the person-centered care approach. So this is the challenge that we often, hear, or dissonance we hear from families and other people.
Yes, I would agree completely. I think what we need to do really as a society is move from task-based to outcome-based, with the person in mind, utilizing outcome as a measurement, i.e. KPIs. What we've done in brief, broad brushstrokes, because I don't want this to be an advert, but we think that prior to a person arriving in a care home setting, what will be better is for the family to create the backstory of the history of that individual, i.e. the life story of that individual, so that when a carer arrives within that care setting to perform out-based task requirements, they can access the historical information about that person, but have meaningful conversation whilst they're undertaking their care tasks. Yes. And that will be, just in very quick terms, more person-centered, because they're actually liaising and having meaningful conversation with the individual with which they're caring for. So that's what we've created, essentially.
Yeah, storytelling has been used quite, widely in many of the places that I've been to. Absolutely. It's a very, useful tool to use, and it's not difficult. What's also important that, the story has to be told to many staff members providing care. What we've seen is sometimes the story is known to a particular staff member, but when you have, high staff turnover, that information may get buried. So I think this is what we are challenged the most in our aged care environment, that, when we haven't looked after those who are providing care, person-centered can can go to the bottom of the priorities, because if staff members don't feel that they are valued and their role is recognized, it's very hard to provide the person-centered care, and then they leave. So it's really important that we see that, person-centered care, not just as a training, approach. So that, that is basic, but then there has to be other elements that actually support staff, the enough number of staff, but also those staff members understanding, how they provide person-centered care, but also they have to be sufficiently remunerated. So I think there are a lot of issues that, come into the equation when it comes to how best we provide a person-centered care. I think, I've spoken to many staff members. Many of them, understand what it is, but they don't necessarily, feel that they have means to provide the care because they are so, exhausted, or they don't have, sense of that they are well supported.
Yeah, no, I would agree with everything you've just said, Dr. Jeon. I think one of the issues is accessibility, really, and what we've done effectively is made the life story available via QR, so it's mobile centric. Everybody these days has their mobile on them, including carers in a care setting. So one click of a QR and they've got the backstory of that individual, I think transcends the issue of accessibility for carers. I certainly agree with in relation to time constraints and task-based environments and the need to be inclusive where the carer is concerned. 100% agree. Yeah, thank you.
Well, thank you very much, both Darren and Yun-Hee. The chat is very active. So we have another question from Denise Swang, Miss Denise Swang, and she asked regarding person-centered care at the end of life care, and whether you can speak on how it might be applied within that context.
So person-centered care, and did you say end of life care?
Yes.
Yeah. Are you talking about, I might need some more clarity around what it is.
No, absolutely. I think Ms. Zwang's question is regarding how people who are, at the end of life within the care system continue to be included in conversations about the care, and how person-centered care can be applied within that context.
Yeah, person-centered care, the principles applicable across all spectrum, in rehabilitation, in palliative care, end-of-life care, all of those. If the question is around, towards the end of life, if it's about decision making, and I guess this is the part that we really need to understand. Often when people, and the definition of end of life is also a somewhat fluid, depending on who you talk to. If we're thinking about, 12 months, before the person dies, depending on the person's medical, health conditions, the person may still have, a lot of, capacity to talk about things. I guess the concern often arises when the person has severe dementia, or they have other physical health issues that preclude them from having their voice. So I think, this is where we, the role of the family, those people who are close to the person is important. Doesn't mean that we exclude the person from the conversation. It has to be partnership. It's really important that we work together with the family or the close person who providing that, intimate support as a friend or relative. So, so the principles are exactly the same. I guess the question is when we don't know how we understand the person's wishes, I guess this is where we, work with the families and others to understand what it is that we can best support. One thing that I want to emphasize is that just because someone has, a cognitive impairment, it doesn't mean they've lost all capacity to participate in decision-making. It looks like many of you already in this cafe, have quite a lot of experience in this area. And we know that there are many different ways to communicate with each other. And asking someone about what kind of food they wish to have. If the person is still able to have food, then it's really important that we don't just, provide the food without understanding what the person's preference is. You may not be able to ask the person, but there will be other ways of capturing that information. And also in terms of decision-making, we hear about, I had a PhD student who interviewed, people with young onset dementia about decision-making. A lot of times people think about decision-making in terms of making will or, financial decisions, but not necessarily day-to-day decisions. What kind of things that they want to do on a day-to-day basis. And the moment the person has dementia, there is that assumption that, other people will make decisions for the person. And that's not something that, those people with young onset dementia wanted. What they really wanted was being part of that decision making. So then how do we support that? It's giving the person enough time, sufficient information that the person needs to know, and then give the person chance to talk about. And I guess that's to a degree when the person has that level of capacity. Once the person has lost all capacity, then I guess comfort is the most important part of their care. And Tom Kitwood talks about comfort as one of the most important needs the person needs to be to have. So I think it all depends on individuals, the health conditions and other abilities that they may have or may not have at the stage.
Thank you very much, Dr. Jeon. And I do have a question regarding digital tools. So with digital tools having the potential to support interactions between person receiving care, individuals, and healthcare providers, how can digital technologies better achieve person-centered care approaches and strategies, particularly in like assisted living spaces or settings, for example?
Yeah, I mean, digital technologies, we hear about them so many different ways. And, in terms of supporting individuals' day-to-day life, there could be different memory aids if the person, often forget about things or taking medications, or there are tools about, different apps that facilitate reminiscence, the stories, or the person likes to enjoy even the personalized music tool. That is another form of digital technology. But I think, whenever we talk about digital technology, we really need to think about these are all aids. They are supporting resources. They are not necessarily going to replace that personal contact and the touch and the conversations that individuals, really want to have. I've seen, the sensors that actually capture information about the person's health condition. Biotechnology is moving really fast, and we're going to learn about individuals, the physiology, the changes that are happening in the person's body a lot faster than ever before in the coming years. These things are really going to help clinicians or those people who are providing care so that they can detect changes faster. There are, equipment like, virtual technologies that really help people to participate in the kind of the experience that they may not be able to go out physically, but they could actually use those the virtual reality equipment to be able to experience things as if they are in the place they couldn't actually go physically, and also there are ways that we can capture individuals' whereabouts, so that the person can actually walk around, the neighborhoods without, the family, without having to worry about the person, getting lost. So there are so many different ways of using technologies. But what we found, most important over and over again is that we need to actually help people to use the technologies. It's not just something we could just hand over and you can use it. It's just, it's again a process, working with the family, if there are members of the family around, engaging other people, also giving the person, in care to be part of the community. I think those digital technologies are going to be really useful to give that kind of opportunities more often than ever when we use them wisely, so that the person is not confined in their own home or at an institution. These technologies are giving more freedom when they are used wisely.
Thank you very much, Dr. Jeon. Mr. Shmuel Gerushalmi has actually posed a question in the chat regarding COVID. So in the era of tackling COVID, we needed more person-centered care. And how, moving forward, can we leverage some of the learnings and the experiences we had from COVID to ensure that person-centered care is continuously implemented in the care of older adults?
Yeah, that's a very an interesting and it's an important question that we all need to reflect on, in terms of what just happened during the pandemic. I guess, those people who are in an institutional care setting perhaps suffer the most than anyone else, given that they were completely isolated from anyone else. And also those who are providing care in their kind of confined environment, especially when they had to wear, masks, goggle, and the gown day in and day out. Things that we learned during the COVID, I think what we learned was the importance of the social contact. So important. A lot of people in aged care home died in a tragic environment right in the middle of the pandemic, with no family present when they died, or, and that created a lot of distress to families and other people. I don't think we necessarily handled well. I think, a lot of people, providers and the government, and, those providing care, they've done what they could, in such challenging environment. But I think, what we really have to do is that what is most important, isn't it? Someone who is in their 80s and 90s, and they're, in a place where they may not have another year or two, but they really wish to be close to their family. And then we are providing some support through, Zoom or, technology device. People could communicate through those devices, but at the same time, they may help, but they're nothing like the real person. So it's a really difficult one, when people are afraid of the pandemic, the infectious disease. And then we also need the individuals, the human rights, to actually have the social contact, the contact from their loved ones. When they don't have that, I don't think anyone has the answer how we actually balance that, because every person has a different view in many ways about what it is they want most. One person may want the social contact. Another person may say that I don't want to have COVID. And how do you balance that in an institutional setting? So I'm sorry that I don't think I have, we've learned a lot about the importance of the social contact, and the social contact could also, it's not just about, social engagement. It does impact on the person's, not just cognition, overall health declines because they just do not have the contact, individual contact. And this is what we're talking about, person-centered care. I don't think we were able to provide the person-centered care in the middle of the pandemic. We provide the care that is required as best as we could, but not necessarily person-centered care was the front in everyone's mind, to be honest. Other people may have a different view.
No, thank you very much for that, Dr. Jeon. We are slowly coming close to the hour, but we do have time for one more question. And I see Mr. Eric Sopon, you put a question in the chat. So right prior to the key takeaways, we can, if you don't mind, may you please pose your question, Mr. Eric?
Thank you, Dr. Yun. The question is simple because it's important for us to get the ratio right between staff and all the persons. And also, if I can add, there is this movement to keep the new services on a smaller scale, for example, up to 30 residents from providers' perspective. Would you agree if it is possible to keep it under 30 and less for the number of all the persons, and maybe avoid creating like a 100 beds, 150 bed facilities? And if we have, and sometimes there is no choice in this, to create bigger facilities, how is the ideal ratio between the staff and the other person? Thank you.
Yeah, that's a really difficult one to answer. And I don't believe the ratio itself is going to give us the solution. But what we do know is that there is a model of care that does actually provide opportunity for professional care. The registered nurse, for example, and other carers who are skilled to provide the care. So in Australia, we had a major the Royal Commission into aged care quality and safety. And what we are now having is that there will be a mandatory, the care minute. So, that every resident in aged care home must receive 200 direct care minutes, because as I talked about, a lot of care is tasks and tasks. There isn't sufficient person-to-person care time. So the government has now, made a law that you have to have 200 minutes per resident per day. And of those 200 minutes, 40 minutes have to be delivered by registered nurse. So this new legislation will be introduced later this year. And has created quite a lot of, anxiety for some of the aged care providers. What I've seen is many years ago, we had, 1:8 ratio. So 1 staff member to 8 residents. I don't think that's based on any specific scientific base. And if you talk to unions, then they will give you different answers. But what we need is the skilled care staff. They must have, every aged care home must have a registered nurse who could actually provide, clinical leadership. That doesn't mean that one person for 100 residents. So it's very much around, I do agree that smaller, care environment is better for person-centered care, in my view. And once you have a larger number of people, it is very easy to become task. I've also seen group home models where you have a home environment. It's very much home-like, environment with, registered nurse and care workers and social worker. It's very much teamwork and provides that very home-like environment. And that really works well. But just because we have a smaller, care home environment doesn't make the whole care home person-centered. So it's again making sure that workforce model is well established. Skilled workforce, skill mix always comes in, and there is sufficient time for registered nurse to understand what's going on and provide the clinical leadership, as well as care workers and enrolled nurses providing the care as a part of the team, rather than, nurse is doing, clinical work only and doing documentations, whereas a care worker may do, giving shower and providing other personal care. I think there has to be definitely team approach, and appreciating that the skill mix, the importance of a skill mix. I don't know whether I answered your question, but I do, agree that smaller environment is more conducive to person-centered care. And, and it is happening, things are changing, but we need to really make sure that there is enough skilled workforce to provide the care.
Thank you so much, Itasia.
Thank you very much, everyone. Thank you, Yun-Hee, for the incredible discussion. And thank you, everyone, for joining and asking all of your amazing questions. Just before going on to our key takeaways from you, Dr. Jeon, I would like to introduce our next week's topic and speaker as well. So next week, we have the opportunity to listen to key expert Dr. Laura McLaughlin and Dr. Aaron Wallace for World Immunization Week, actually, on the work of the Immunization Agenda 2030, specifically life course and integration. So it's going to be a great discussion, and we hope everyone joins to hear it. So back to you, Dr. Jeon. In just a few sentences, may I ask for your key takeaways to share with us all today, please?
I thought about a lot about these takeaway messages, but what I want to say today is that in Australia, we are facing a great deal of challenge in securing people who would like to work in aged care, to provide a care of all the people in a care home in the community. And what I really want to say, it's our societal responsibility to value the care. And I think, we need to have hope. We need to make sure that those who provide care, their role is well recognized and valued and remunerated. And so that all the citizens and our residents in aged care homes are guaranteed best care possible. And I think, without that, I think we're going to have a really tough time. And I do hope our policymakers and, drive that change, and they are trying, but I think we as a society, the ageism must be tackled. And because I think ageism plays a significant role, a lot more than people, would like to admit. And, without tackling ageism, we still have a long way to go.
Thank you very much. Thank you, everyone. And I hope everyone has a great rest of your day. And we hope to see you all next week. Thank you.